So with that, I'm going to ask Karen Clayton to come to this stage. So Karen is the current president of Lung Cancer Nurses UK. So she knows all things lung cancer nurse, and she's going to take us all through what we should expect from a lung cancer nurse. Thank you very much, Karen.
Thank you. Thank you very much. So thank you very much. It's a different crowd for me on a Saturday afternoon, this, because I'm usually at the football. But you look a friendly bunch, so thank you very much for the invitation to speak today, and thank you to Deborah and the organising committee. I'm Karen Clayton, I'm a Macmillan lung cancer nurse. I have a dual role as being a palliative care nurse as well. And I'm current chair of Lung Cancer Nursing UK. Lung Cancer Nursing UK was set up to provide peer support for lung cancer nurses all over the country, and also education. And we have representation in all 4 countries, which we're really proud about. The team I lead in East Cheshire, which for those that don't know is just about 20 miles south of Manchester. We support our patients from pre-diagnosis all the way through to end of life. We see them all the way through diagnostics, oncology, treatments, follow-up, and then on to specialist palliative care in hospital and at home. But not every lung cancer nurse service is set up like that. Some lung cancer nurses will only do diagnostics, some will only do oncology. And even though we've all got the same job title, it really does depend on the service position, provision, should I say, of your local hospital. But that doesn't mean that every lung cancer patient shouldn't have equity of care. So they're my disclosures. And then we're going to move on to aims. So I'm just going to explain why we have lung cancer nurse specialists, the importance of our role, what we can do, and then I just wanted to end on what you can do for us, because a therapeutic relationship is a two-way street. So, why do we have lung cancer nurse specialists? Well, in 1995, Kenneth Kalman and Deirdre Hine, the chief medical officers for both England and Wales, produced a report to improve cancer care across the UK. It was the first comprehensive report, set out principles of care, and the recommendations included strengthening patient-centred care, creating networks to ensure all patients lived, wherever they lived, had access to receive high quality of care, and concentrating on multidisciplinary team meetings and specialist team working. The first tumour-specific nurse role was developed, and it was actually developed in colorectal care, but it was evaluated and it was decided that every single tumour group should have its own tumour-specific nurse. The National Institute of Clinical Excellence in 2012 actually put a quality statement out saying that the lung cancer nurse can provide specialist guidance and support at all care stages of care for patients. And they also recommended that one whole-time lung cancer nurse could look after 80 new patients. Now, when I talk about whole-time lung cancer nurse, that's one full-time nurse looking after, for working 37.5-hour week, which I wish I did, looking after 80 new patients. Now, back in 2012, when we didn't have all these fantastic new drugs and we didn't have very clever people like Dr. Greystone, Dr. Shah, and Dr. who come up with all these drugs, 80 was probably about right. It was probably about right because the caseload did ebb and flow. Patients came on, patients came off. Nowadays, that's nothing. 80 is nothing. And of course, we're looking after patients for years, not just new patients. So we've just put Lung Cancer Nursing UK have been working hard with the CEG, and we've just put a paper towards to see whether we can do something about that figure. Every trust has to provide evidence of local arrangements to ensure that adults with lung cancer know how to contact their clinical nurse specialists between hospital visits, and they are monitored and they are benchmarked. And then recently we've had the National Optimal Lung Cancer Pathway, which is a standard approach, which includes the role of the lung cancer nurse specialist, acting as point of contact, coordinator in all areas of a patient's care. Now, I'm just going to show you this, and I don't expect you to digest it, because this is massive. But that's part of the pathway. But you can't really see it, but where that red circle is, which is moved, it says assessment by lung cancer nurse. And as you can see, it says day 1 to 6. So day 1 to 6 is probably when we've just got an abnormal scan. And we're meeting the patient for the very first time. That's the time you should meet a lung cancer nurse specialist. You might not know them as a lung cancer nurse specialist at that time. I certainly have a badge that says lung nurse, because we don't know it's cancer at that point. So, but that's when you will meet them. So, what's the importance of the role? Well, the specialist nurse is reduced treatment costs, which obviously goes down well with our managers. We increase efficiency, we drive innovation and provide valuable information for service redesign, as well as enable multidisciplinary care and communication between the different teams. There's lots and lots of teams involved in a lung cancer patient's journey. And from the respiratory doctors to the oncologists, to the surgeons, to the radiologists, to the pathologists. And it's about coordinating all that information so it's in one nice, easy bundle for then to give to the patient. And that's where the MDTs come in. We have some very heated MDTs. Do you have some heated MDTs, Dr. Greystone? He's not looking at me, but never mind. But we do. And we will act as the patient's advocate at that MDT. Because we meet patients at day 1 to 6, we can have a conversation with them about what they might want to engage with treatment-wise. And some patients will say to us, I am going nowhere near a surgeon, or I'm not sure about that chemotherapy. And it's about gauging what they would want. So when we go into MDT, we can actually act on your behalf and say, well, actually, Mr. Bloggs said he didn't really want surgery. Is there an alternative? And then we can discuss the alternative. And some patients don't want anything. And that's fine too, because as long as you've got an informed choice, that's absolutely fine. We recently had a patient who was very young. Well, she wasn't. She was 72, and she had a very early stage lung cancer. And she was a yoga teacher, and she actually did the splits in clinic, which we were all amazed at. But she turned around and said, thank you very much for the diagnosis and goodbye. And she walked out of the clinic, and she won't have anything. And she said, no, I'm not having anything. She's on our follow-up, but and she's adamant she's having no treatment. So, you know, whatever a patient decides, as long as they've got an informed choice and they've been given all the information, then that's absolutely fine. We do have a target set of 85% in the fact that we have to see 85% of our patients across the UK, and the current National Lung Cancer Audit, we sit at 72%. Which means that 28% aren't seen along CNS, which cuts quite deep, really. So we really do need to work hard at improving that. The next stat, which I thought was quite interesting, the patients who see a lung cancer nurse are 2/3 more likely to get treatment. And people look at that and think, why? Why is that? And it's all about the advocacy. It's all about being on the side of the patient when we're talking about treatments. It might be that someone is quite frail when they come to see us, and it's decided that actually treatment isn't in their best interest, but they really want to have treatment. So it might be that we work with them to improve their nutritional status, might help them with an addiction, you know, stop smoking or alcohol or whatever is causing the problem, see if we can get them a bit stronger. And then we can maybe say, well, can we see an oncologist and see what's available? And that was from the National Lung Cancer Audit. So I thought that was quite interesting. And then report by Roy Castle showed that lung cancer nurses provide vital follow-up services of treatment, including palliative care. Where I work, I have 2 nurse-led clinics a week, and we have surgical patients in there. So patients will go off, have the surgery, come back, and we will follow them up under a strict protocol for up to 5 years, although There is talk about extending that now to 10 years. And then same with radiotherapy, same with some systemic therapies as well. And also palliative care. Because of the strains on community services, shall we put it that way at the moment, you'll find that a lot of CNSs are actually dealing with a lot of palliative patients and a lot of symptom control. And if you can come and see us, all well and good. Where I work, we'll come and see you. But I won't come and see you if you're going to have your hair cut, because you can come and see me then. So we do work it out between us. A lot of CNSs do follow-up clinics for TKIs. You know, a lot of patients won't see an oncologist, they'll see the nurse specialist instead. And that's fine, as long as you're getting the service that you require and the follow-up and the support that you need. So what do we do? Well, we act as key workers across the whole of the care pathway, like I've said. And if I've got a patient, I work in a diagnostic, little DGH, and we diagnose and we'll send our patients, sometimes we'll send our patients down to the Christie at Manchester. And if that patient's needing support locally, then the Christie nurses will ring us and ask us to get back involved. And it's very much an ebb and flow situation. We've all got advanced clinical diagnostic skills. So we can all, most lung cancer nurses would have done clinical masters and can examine a patient like a doctor can. Not as good, well, no, I won't say that. So we've all got those skills, which is needed, because if you come in on nurse-led follow-up, a patient expects to be able to be, have the same quality consultation if they were in front of an oncologist or in front of a respiratory consultant. That's my view, and that's what I expect of my team. We have in-depth knowledge of a tumour group, obviously, that goes without saying, but trying to keep up with everything is quite hard, it's quite difficult for those that are working in it every day. So what it's like for those that aren't working in it every day, it's a minefield. And we will get called to wards, we'll get called to the wards, we'll get called to A&E when there's a suspected new patient coming or a patient's coming on a treatment. We'll work very closely with our acute oncology nurses to make sure that things are running smoothly for that patient. The ability to assess patients' holistic needs. So now, I'm not sure how many patients in this room would have had a holistic needs assessment at diagnosis. I am a Macmillan nurse, and it is one of Macmillan's projects, and we are mandated really to do a holistic needs assessment. And for those that don't know what one is, it's a document where you fill in any problems with physical, emotional, psychological, social, financial, anything that's causing you a problem in your life apart from the lung cancer that we can help you with. Because we leave the treatments and what have you to very clever people, like the one on my left. And we deal on the more of the quality of life aspect. And it might be something that's absolutely nothing to do with a lung cancer diagnosis that's causing the problem. So like this time last year, we had a chap who had turned up for all his diagnostics, absolutely not a problem. And we needed him in clinic on a Wednesday. We have our MDT on Tuesday afternoon, so in clinic on a Wednesday. And for 3 Wednesdays running, he didn't turn up. And we thought, what is going on with this man? Why can he not come to clinic? And I can't take credit for this. This was one of my team. She actually got hold of him, managed to track him down, and said, you need to come to clinic. What on earth's going on? We need to treat you. And he said, I can't come on a Wednesday because that's when the food bank's open, and if I don't get me food, I won't have anything to eat for the week. Right, okay, understand now. So he came in on another day, and we got him over to the oncologist, but meanwhile, we got him referred to the welfare rights officer to make sure that he got all the benefits that he needed. We got him into the dietitian to make sure his nutritional status was sorted, and we referred him over to mental health services for his alcohol and smoking addiction. So that's what I mean by holistic care. It might not be anything to do with the lung cancer that's causing the issue. But and I would argue, actually, we don't need a piece of paper. As a skilled CNS, you could pick that up. Advanced communication skills and advocacy skills, where they go without question. You know, sometimes we have to have very difficult conversations with our patients. And sometimes our patients take us to places we don't want to go, but we will. So, yeah, that goes without question. Empathy and patience. I stand here before you and I don't mind saying that I've sat and cried with patients, but I've also sat and laughed with patients. So, yeah, I wouldn't be human if I didn't have some empathy in the work that we do. We have excellent decision-making skills. We've always got a ton of balls up in the air, making sure that we're doing everything that we can. I was told by a matron of mine when I first qualified, as long as you keep the patient at the centre of everything you do, then you won't go far wrong. And that's definitely what I preach to the team. Leadership within the MDT. I'd probably say something quite controversial, but consultants are led, although they probably don't need it, probably don't know it. It's very subtle. But yeah, and we provide leadership within the team. And also that communication with the wider cancer team of what's gone on and what is going on for a patient. We like to change, we've got to change. You know, the past 12 years in lung cancer has exploded, so we've got to change, we've got to move with the times. It goes without saying that we've got a lot of things to do, but we can't do it without you guys. So, what can you do for us? Like I said, a therapeutic relationship is a two-way street. And although we can do as much as we can for you, you can actually help us too, by telling us what you want, instead of letting us guess or try and tease it out. Never ever underestimate the power of your voice. I could bang on to my managers for days and weeks and years that I need a new nurse, I need another nurse. But as soon as a patient says, I can't get hold of that nurse, she'll be on the phone to me going, why is no one answering that phone? And I'll say, well, there's not enough of us. So, you know, don't ever underestimate the power of your voice. And that's just a little quote from Ralph Waldo Emerson, which I think is quite profound. What lies behind us and what lies before us are small matters compared to what lies within us. So in conclusion, and I think I've probably rattled through that quite quickly, is a lung cancer nurse are highly educated, motivated people. I'm going to say that, aren't I? Stood here like that. We advocate for patients regionally, nationally and internationally. I sit on our local GM and Cheshire, Greater Manchester and Cheshire Lung Cancer Board as nurse representation for my trust. Nationally, obviously, I lead a team of 12 lung cancer nurses on our committee, and we are present at we've got representation on NICE and different areas. And internationally, I was lucky enough to go to San Diego a few weeks ago to World Lung and raise the profile of lung cancer nursing in the UK to colleagues around the world. Patient's voice can help us, like we can help you. And if I would really encourage you to use your lung cancer nurse. And if you can't get hold of them, I wouldn't like to think that you were being ignored. I would like to think it's because the workload's too overwhelming and they haven't got the time, which is very sad indeed. So there's my references. And if anyone's got any questions, and remember, no question is a daft one. Thank you.
Who wants to kick us off with a question?
I've stunned them all down.
You have?
Hello, thank you for the presentation. You mentioned your target is seeing patients post-diagnosis from day 1 to day 6.
That's pre-diagnosis.
Pre-diagnosis.
Yes.
I'm just thinking, would it be helpful to make it like the pathway at diagnosis, patients to be seen from first day? Because those few days of waiting, not knowing what's happening, while someone being given, usually through A&E, the CT result of having stage 4 cancer, which happened to me over the phone, and then waiting for some days until the specialist will see you and start the investigation and the journey. Those few days are critical. And
Absolutely.
I was lucky, a colleague who has a different type of cancer told me about finding a forum, and I found ALK Positive UK after a few weeks, and that was the first time I was given hope. So I think those few first weeks or days are quite crucial if they can be seen by a specialist nurse.
Oh, absolutely, absolutely. I mean, what's happened to you? No, that shouldn't happen. Well, I say it shouldn't happen, but unfortunately it does happen. When it's day 1 to 6, that's pre-diagnosis. So that's when a patient will come into what we call a rapid access lung clinic with an abnormality on a scan. That's that time, and that's where we will have a nurse in that clinic at that time. So when you've gone through all your investigations and you're coming back for the results, you've met us already. You won't know that, but you've met us already. And sometimes patients will decide to have their results over the phone, and if that's what a patient wants, then that's absolutely fine. But at least they've seen us and we can ring them. We do go to A&E. I've been called to A&E many, many times to come and see a patient. But again, it's what's different in different hospitals, isn't it? But you should have had a lung CNS contact when you were told, whether you were on the phone or face-to-face. So I'm sorry you didn't. Oh, I've got to be careful now.
It should be a nice, simple question. So first thing to say is I couldn't do my job without the CNSs that I work with. They are absolutely invaluable. Excuse me. So I had a little bit of chat outside, and we were also having a discussion on a webinar the other day with an oncologist down in London, and you mentioned nurse-led TKI clinics. We also use them for follow-up, as you do, and we even use them for our long-term immunotherapy. So the question we were talking over as oncologists and have very different views on is when do we feel comfortable for a patient to move to a TKI clinic or a follow-up clinic? And also what structure needs to be in place for a nurse to deal with when things do go wrong? So does a nurse-led clinic need to run alongside an oncologist? Does she need to have ready access to the oncologist? Should she be happy to give the bad news and refer back? And what that looks like. So how does it work for you, and what's your view with your more organisational hat on as to how that should work from a CNS point of view?
Well, first of all, I think the CNS needs to have the qualifications and the experience to be able to deal with to be able to do the clinic that they're being asked to do. That's number one. Number two, we do need to grow the confidence of the oncologist that his patients, her patients, are being looked after well in a nurse-led clinic, and anything that is comes up, that we will, it's that communication, isn't it? Our clinics on a Monday and a Wednesday, my nurse-led clinic, I'm being pushed to do another one, but they can give me another nurse first. They run alongside the respiratory consultants. So if I've got a problem, I open my door. And I think that's probably where it works best, the fact that you know that, A, they can come to you and you can come to them. And be in that close vicinity. I think that but the person that's doing the clinic has to have the training to be able to do the clinic and know what they're looking for.
Okay. Any other questions? I don't think so. Oh, right.
I just wanted you to go to the previous slide. Immunity worked out.
That one? Oh, okay.
Right.
Okay.
We'll leave that there for a minute.
No, don't worry.
Oh, there is a question.
Aaron.
No?
We need a microphone.
Oh, sorry.
Can I ask about named nurse and the requirements for patients to have a named nurse? And is there any difference between inpatients and outpatients?
There can be. Like I say, it depends how the team's set up. Some nurses, some clinical nurse specialists will only work in outpatients. They won't see inpatients. So those inpatients are left to the nurses on the ward, the doctors on the ward, and then they'll see them if they're discharged and come back into clinic. Some teams, like my team, will go and see a patient on the ward as well as seeing them in outpatients. It really depends how it's set up. But a named nurse, we stretch that a little bit and go a named team, because I wouldn't want a patient ringing in for me and I'm on 2 weeks holiday and thinking that they can't ask somebody else. You know, so we go, it's very much a team approach to having a named. But everyone, you should have access, you should have a number that you can ring if you've got a problem.
So just following up on the statistic about only 72% of people having a named CNS, I'm involved with the NLCA, and what I would say is that particular data point, the data quality is quite low. So it could be higher, it could be lower than that. We don't know, but the data quality is pretty low. So it's kind of, shockingly, the other data quality point that's really low is whether people smoke or not. Mm-hmm. And that is really shocking, because we should know that for 100% of lung cancer patients.
Absolutely, you're quite right. The data's only as good as the person putting it in the data sheet, isn't it? And I think our cancer trackers are very good at picking up a stage and very good at picking up someone's treatment and diagnosis, because they can read a letter and find it. If it's not in the letter, they won't know. So if it's not in, so for example, I've asked our consultants to put that we were present, so it's in the letter, so they can pick it up and they can fill that field in. But also, a lot of nurses, a lot of CNSs have to do their own data as well, on top of everything else. So it can be quite a difficult chore, if you like.
So the other thing I was going to just make a point about the holistic needs assessments. My own experience of those was that I probably had it too early, and I had no clue what was going on at the point that I had my HNA.
Yeah.
And I probably needed something at that point, but the full HNA would have probably been better a month later when I was settled into
treatment, and you knew what was happening and you got a plan.
Yeah.
And that's been my bugbear for a long time, to be fair. So we are mandated by Macmillan to do it at diagnosis, and I've always said that's probably not the right time. So we do stretch it, and we will do it when someone comes back on follow-up. So we will stretch it, but it's up to the patient, really. And some patients don't want it, and that's absolutely fine too, you know. Oh.
Hi.
Hi.
2 questions. The second one's a silly one. First one, I'm surprised speaking to some other people. When I go to A&E, when I need to, which obviously sometimes you need to, at the Royal Marsden we have a yellow card that we show people when we check in at A&E, and you know it shows that we've got medical issues, obviously, and ideally if we can be kept away from people coughing and spluttering and stuff like that. But there doesn't seem to be a national thing on that. Is that something that would sit better with the lung cancer nursing UK?
Yeah, probably.
Okay.
But yeah, you're right. You know, different hospitals do different things, don't they? Different hospitals have different flags for different patients. At our hospital, it's on a computer flag, so your name comes up and it'll come up that you're on cancer treatment immediately. But again, it's about you working with the team, isn't it, and telling us actually, you know, I am on this treatment and I really do need, because they're non-specialists in A&E, aren't they?
Yeah, very. The second one, so your football team then, Wrexham, Chester, or some horrible Manchester?
Well, I did check the score before and they were drawing, so if you know who's playing at the moment. I don't know whether they lost or not, but it's the blue side of Manchester.
Not Wrexham.
Thanks, Damon. So, thank you very much indeed, Karen.
You're welcome.
And I'm sure we'd all like to show you our appreciation.